Hi guys, welcome back. We shall now be talking about large airway disease, bronchiectasis. The highlight of this disease would be destruction as well as dilatation of the large airways. Therefore, these airways would now be filled with pus and would result in a clinical feature by the name of bronchoria. Do remember the fact that bronchoria is also read by you in literature of chronic bronchitis. So in a lot of clinical based questions, the skill of yours would be to identify small airway disease versus large airway disease. And one of the hints that I can say right at the beginning is that chronic bronchitis does not have clubbing, whereas bronchiectasis mostly has association with clubbing. So if you are reading a question that begins by saying bronchoria, cough, productive cough in a patient, dyspnea on exertion, and routine features of respiratory system, and then mentions the presence of clubbing, then you should think in terms of large airway disease in a patient. There are multiple other differences also that I will try to make you understand as we progress in the disease. Do remember, from the histopathological perspective, the most common subtype of bronchiectasis is the cylindrical variety. It is also called as the tubular variety. That simply represents that the airways are dilated, they are thick walled, they are filled with pus, and most of the time in these patients, infections could be with dangerous organisms like pseudomonas, which is notorious to cause a biofilm in the lung, and therefore even if you give the best quality antibiotics, the antibiotics will never reach the main site, and therefore the pus will continue to be produced, and gradually the person can expire secondary to the manifestations in the patient, which can be something as severe as the pus area keeps on expanding, it erodes into a blood vessel. So one of the reasons why patients of bronchiectasis can die is due to massive hemoptysis, for which you might have to intubate the patient, secure the airway, and even if you do a bronchial artery embolization, the damage can be so extensive by the suppurative process that it would be difficult for you to save the person, and therefore we need to identify the disease relatively earlier also. Most of the time in the textbook, the causes have been subdivided into focal and diffuse. Well, focal would mean that there could be obstruction, and then subsequently there is an infection developing followed by accumulation of pus. Now, why would there be an obstruction? Either it could be to aspiration of a foreign body with respect to a child most of the time. In adults, however, the obstruction will mainly be caused physically by a lung tumor. It could be a benign tumor like a pulmonary hamartoma or a bronchial carcinoid that will encroach onto the bronchus, obstruct the bronchus, and then first it will cause collapse of the lung segment. Secondarily, there could be infection in the underventilated lung. You will always notice that when the lung part is underventilated, I'm not saying that there is no ventilation, I'm saying underventilation. So underventilation predisposes to stasis of secretions in the lung, and that's where the bacteria can multiply, because the air that we breathe in could be having bacteria. So underventilated lung is rather predisposed to development of infection and then development of suppurative process ending up with bronchiectasis. When it comes to the diffuse process of bronchiectasis, that's multiple lung fields could be involved: upper lobe, middle lobe, lower lobe. In fact, bronchiectasis can affect any lobe of the lung. It is just that you need to appreciate that if suppose a person is having tendency for chronic aspiration or recurrent aspiration, like suppose somebody is having bulbar palsy, person had stroke of the brainstem, he's having bulbar palsy, his gag reflex is not there, so recurrent aspirations can occur because the gag reflex operates on 9/10 nerve. In bulbar palsy patient, there would be no gag reflex, so recurrent aspirations will result in development of mainly the lower lobes getting involved, because due to gravity the pus will tend to go a little downwards, so lower lobes are more commonly involved, whereas in tuberculosis and cystic fibrosis, it is the upper lobes of the lung which are relatively more involved. So depending on the etiology, various lobes of the lung or more than one lobe of the lung can also be involved. One of the important diffuse process that you need to understand is the infection component. The bacteria that I'm talking about is not only pseudomonas. I mean, pseudomonas is a dangerous one, as I've explained. This can form a biofilm in the lung. It will be impervious to antibiotics. But over and above this, I want you to remember two more dangerous organisms which can affect mucociliary clearance. One is Mycoplasma pneumoniae. Mycoplasma pneumoniae is inherently resistant to beta-lactams. You have to give macrolides. Now, a person had Mycoplasma pneumoniae, atypical pneumonia. He did not come to a qualified doctor like you. He went to some RMP doctor who was giving beta-lactam, and the person will continue to deteriorate. So, lots of time Mycoplasma pneumoniae, though it can be treated by macrolides, it is not treated on time. Therefore, the disease process can be more extensive and can result in a sequelae or a complication of bronchiectasis. Another bacteria from pediatric perspective that is to be remembered is Bordetella pertussis. Pertussis is also called as 100-day illness. So the impact of the bacteria is pretty severe that it remains in the lung for relatively long duration and can affect mucociliary clearance. In our lungs, we have a mucociliary escalator which keeps the lung clean or devoid of bacteria, and even if the bacteria multiplying, the immunity will kill them. But if whenever there is a hampered or a reduced mucociliary clearance, the incidence of infection will definitely increase. After infection, the next important cause to be remembered are causes like alpha-1 antitrypsin deficiency, cystic fibrosis, and Kurtenegger syndrome. Each of them are themselves an explanation, so we will handle these explanations here only rather than me first mentioning the entire table and then going into individual causes this time, because these are highly important diseases, so aspects of these have to be understood here only. The subsequent cause of this condition is a decrease in immunity. That could be explained by conditions like HIV and AIDS, which are, however, easy for anybody to answer. So, in multiple choice questions, in the causes or etiology, he will usually write this term hypogammaglobulinemia. Lower immunity means more susceptibility to infections, and rather those infections can be relatively more severe also. The subsequent cause that is to be remembered is a genetic cause. This could be alpha-1 antitrypsin deficiency, cystic fibrosis, or lastly Kurtenegger syndrome. In fact, these causes are the main reason why bronchiectasis ever is gonna be asked to you. So I will have to handle the manifestations here only. In alpha-1 antitrypsin deficiency, the problem is not a production, it is being produced by the liver. It is rather that it is not being released by the liver. The basic function of alpha-1 antitrypsin in our body is neutralization of elastase, which is produced by the alveolar macrophages. Why macrophages produce elastase? Because of response to dust, pollution, smoking, and when we go out in the atmosphere, like India is one of the most polluted countries in the world, so every time we are breathing Delhi air, Bombay air, whatever, then our macrophages are producing elastase. Thankfully the activity is neutralized by alpha-1 antitrypsin, but if the production is very much there but it will not be released, then alpha-1 antitrypsin is not coming in the circulation, so the activity of it to neutralize the effect of elastase will not be there, and this will explain that in these patients, one, there can be damage to the airways very extensive, that is pan-acinar emphysema. There could be secondary infections then developing in the patient in the airways, which can explain the bronchiectasis component of the patient. And alpha-1 antitrypsin is not getting excreted, it is being produced, so it will accumulate in the liver, and therefore you will be having liver cirrhosis developing in the patient. The manifestations of alpha-1 antitrypsin deficiency can be pan-acinar emphysema, bronchiectasis, as well as cirrhosis developing in a patient. In contrast, cystic fibrosis is a separate lecture that I have taken, but I'll just mention the salient features. This occurs due to F508 mutation. It's an autosomal recessive condition, and this is due to defect on chromosome number 7. The problem in this condition is that the mucus of the airways is extremely thick, and therefore because it is thick, therefore it is also called as mucoviscidosis. There is no problem with the motility of the cilia. All cilia in our lung beat in the same direction. We call it mucociliary escalator. They beat in the same direction. They keep our lungs clean. What happens in this condition is that the mucus is very thick and viscid, so it is sticking to the airways. So even if the cilia will beat, they will not be able to keep the lungs clean, and the stasis of secretions will be ultimately responsible for infection, and that can translate into bronchiectasis. In contrast, when it comes to Kurtenegger syndrome in a patient, here the problem will be that of cilia are there, but they're not going to function. Due to genetic reasons, in the dynein arm, there is a immotile cilia present in the patient that will predispose to again lung infections. In fact, there's a triad of Kurtenegger that I would like to handle here only. The first feature of Kurtenegger syndrome would be recurrent sinusitis in a patient. You see our sinuses have ciliated columnar epithelium, the cilia is not functioning, so recurrent sinusitis. Recurrent lung infections in the patient will translate into bronchiectasis, and most of the time in the topic of Kurtenegger syndrome, he will also give you a X-ray in which you will notice that the heart of the person will be present on the right hand side. There would be situs inversus or organ inversion in a patient. So either he might say that there is a heart which is right sided or liver of the person that is left sided. So organ inversion would be mentioned. Do remember the fact that in Kurtenegger syndrome, infertility, though present in males, it is not a compound of the triad. Why that is so is because infertility is not seen in females with Carteneger because the tubal peristalsis is the main determinant of movement of the ova. You see, when the ova moves in the fallopian tube, there are two reasons why it moves. One is the tubal peristalsis component. Second is the cilia present in the fallopian tube. Do appreciate the fact that even if the cilia are not functioning, still the tubal peristalsis will still cause the ova to move and then goes into the ampulla and then fertilization can take place. So infertility in these patients is definitely seen in male patients. Why? Because the sperm motility, the tail of the sperm will not move normally. So sperm motility is hampered in the patient, but infertility is usually not encountered in female patients of immotile cilia syndrome or Carteneger syndrome. Why? Because the motility of the ovum is not dependent on the movement of the cilia, but is more dependent on the tubal motility component. On the other hand, because males will be having it, females will not be having it, so it's not a constant feature, so it has not been included in the triad of Carteneger syndrome. That's one of the important aspects that I wanted to remember. In contrast, cystic fibrosis patients, infertility will be seen in both men and women. Do remember my facts. In cystic fibrosis, the infertility that occurs in males is because of agenesis of vas deferens, whereas infertility that occurs in cystic fibrosis in females is due to thick cervical mucus plug, because normally at the time of ovulation there is spin barkade, the cervical secretions are thick. Here the cervical secretions are very thick and viscid. They block the opening of the cervix, so the sperm penetration is not going to occur. Therefore, do remember this statement of mine: cervical mucus plug can contribute to obstruction and thereby infertility in a female of cystic fibrosis. In cystic fibrosis, infertility is seen in both the genders, but infertility is not found in female patients with Carteneger syndrome. And these are three genetic causes for development of bronchiectasis in a patient. Always in patients of bronchiectasis, in image-based question or in theory, clubbing will always be a presentation. I highlight the feature bronchoria given with clubbing. You first have to think in terms of large airway disease in a patient. The remaining two causes for development of bronchiectasis are autoimmunity and recurrent microaspirations developing in the lung. The autoimmune disorders worth remembering are rheumatoid arthritis, Sjögren syndrome, that is also called as Sika syndrome, having dry eyes and dry mouth, and surprise, entry here, inflammatory bowel disease. Why rheumatoid arthritis would cause this is because rheumatoid arthritis has rheumatoid nodules. Those inflammatory nodules will cause local damage, and once the damage is there, then there can be fibrosis also, and that fibrosis will distort the anatomy of the airway. So you will read the term traction bronchiectasis, which could be seen with autoimmune disorders. The next entry might look very surprising if you're reading for first time ABPA, allergic bronchopulmonary aspergilloma. The surprising thing is that I'm talking about a fungus that is having an allergic manifestation. Please appreciate that allergic bronchopulmonary aspergilloma is not a colonization of the lungs by Aspergillus species, but it is rather a hypersensitivity reaction to the fungus. This fungus by the name of Aspergillus fumigatus can be present in even saliva and sputum of you and me, but doesn't cause any problem. But in these patients, the hypersensitivity reaction to the fungus results in local damage in the lungs. The predisposition for this condition will be asthmatics. So most of the time the question will begin by saying asthmatic is presented to you with brown to black sputum plugs. That would look very surprising for anybody, and especially a non-medico asthmatic with black sputum plugs is going to seek your advice. And you will notice that for diagnosis of this patient, you will have to do two things. One will be a CT that will show central bronchiectasis. That's the highlight of this entire topic. Majority of MCQs that are asked on the topic of bronchiectasis revolve around this term, central bronchiectasis. Why? Because normally bronchiectasis involves either the lower lobes or involves the upper lobes, but this condition has mainly middle lobe involvement, and this is a hypersensitivity reaction to fungus that is not Aspergillus niger, it is Aspergillus fumigatus. The diagnosis of this condition is made by checking for antibodies. Don't answer sputum culture because this organism is present in the sputum of your and mine also. So it is the antibodies which are to be used for diagnosis. So it is serum precipitants against the Aspergillus species which helps in knocking the diagnosis or helping in diagnosis of this condition, which causes central damage or middle lobe damage, contributing to bronchiectasis. In contrast, when it comes to aspiration developing in lungs, one cause of aspiration can be, a person is having, I would say, aspiration occurring in lungs after drug overdosage, alcohol overdosage. He took a cocktail of alcohol plus drugs at a holy festival, and then he's sleeping continuously for 2 days. So the aspiration that will occur might be so large volume that it can cause a lung abscess formation. Here I'm talking about recurrent micro aspiration developing in a patient. So let's look at conditions that can cause a recurrent micro aspiration developing in the lungs of a patient. One cause for this is mentioned as an autoimmune disorder. I could have written this autoimmune disorder superiorly also, but instead of writing it in the autoimmune disorder, I'm writing it here. Scleroderma. Scleroderma causes fibrosis. Sclero means fibrosis, derma means skin. There is fibrosis even in the esophagus. This condition has esophageal dysmotility, which can predispose to recurrent aspirations in a patient, because the food that the person is consuming will not go down in the stomach. Person will say, I eat little bit, I feel full. When person is lying supine, the food might go in the lungs of the patient, and this would be, not a very large amount of food products, or I would say sudden aspiration of saliva by the patient or sputum by the patient. It would be micro aspiration that would be occurring. So recurrent micro aspirations in scleroderma, or a person who is having airway defense mechanisms which are compromised, like this is a patient of bulbar palsy. He had a stroke 6 months ago. He cannot even talk properly because of the vagus nerve getting involved in the person. So these patients could be, because they're lying in the bed for most part of the day, can end up with damage to the lungs and infection component, that is recurrent aspiration. Let's have a quick recap at the common causes of bronchiectasis. I said for diffuse variety, focal is straightforward, though you don't bother about it. It is to be remembered as infection by these nasty bacteria. Immunity part is easy, HIV. Then can be genetic causes, all three to be remembered by you: alpha-1 antitrypsin, cystic fibrosis, and Kaltenegger syndrome. And last two causes are autoimmunity and recurrent aspiration in a patient. Once you get the causes right, now you will also be in a better position to understand that which lobe of the lung will be involved in which condition. Like for example, if he says upper lobe bronchiectasis is commonly found in, then one standard answer is tuberculosis. That's easy for you to answer because TB commonly involves the apex. So I wanted to remember cystic fibrosis is an important cause of upper lobe bronchiectasis. Another cause that I can spell now for upper lobe especially is post-radiation fibrosis. I did not mention that in the causes initially because then you may not have realized the significance of this cause, but now I'm saying post-radiation fibrosis causes traction bronchiectasis. Radiation damages the airway anatomy, so it distorts the airway and can cause upper lobe involvement. That's a predisposition that radiation is usually given for enlarged lymph nodes in the chest, like hilar lymphadenopathy, which can cause superior vena cava syndrome. So if you are gonna give radiation in the upper part of the chest, mostly there would be a upper lobe involvement, more commonly seen as compared to lower lobe involvement. Lower lobe involvement, on the other hand, is mainly seen with people having predisposition to aspiration. Esophageal dysmotility, whether it is scleroderma or rather severe long-standing undiagnosed HLHA cardia, can contribute to this. Then repeated infections. The conditions having low immunity like hypogammaglobulinemia will result in repeated infections and a lower lobe bronchiectasis in a patient. And lastly would be middle lobe involvement in cases of bronchiectasis. If you get the middle lobe causes right, you are bang on spot for getting the questions right for this topic, because majority of the time they've asked about what I'm telling you right now: allergic bronchopulmonary aspergilloma causing a middle lobe involvement, Kaltenegger syndrome, infection with non-tuberculosis mycobacteria. Mark my words there. Mycobacterium tuberculosis has predisposition for apex, but non-tuberculosis mycobacteria would be middle lobe damage to the lung. The last cause is optional if you want to remember it, because it's given in Harrison. I'm mentioning it, has never been asked, and I don't think so they'll ask it because it's ultra rare William Campbell syndrome. This condition is a cartilage defect related to the airways, so the anatomy of the airways is distorted, and as I've said, if the anatomy is distorted, the tractional force will result in the airway getting distorted and enlarged, that is deformed airways, and then there could be secondary infection contributing to bronchiectasis in a patient. This I would rate as one of the most important slides for the topic of bronchiectasis, where lobe involvement is the one that is being asked nowadays, with the most important ones being ABPA, Kaltenegger, and non-tuberculosis mycobacteria as important causes of middle lobe bronchiectasis in a patient. For tuberculosis, coming to the clinical features of bronchiectasis, the features are straightforward. He will describe productive cough in a young individual. Predispositions may be given, like he might begin by describing cystic fibrosis patient or person who's already had tuberculosis, had radiation exposure to the chest, and even if he does not want to give all those risk factors, he might just begin by saying that a young adult has come to your OPD, he's having history of productive cough for large number of months, he has shown various doctors, but the foul smell in the sputum still persists, that is bronchoria. If I was reading these two manifestations and even breathlessness on exertion in a patient, I could have first think in terms of lung abscess in a person, but then lung abscess will always have a very short history and predisposition has to be given in lung abscess, like a ICU patient or alcoholic patient who was having impaired airway defense. In this question, it would be a relatively longer history. How would you differentiate from chronic bronchitis? Well, you will be having auscultatory finding in chronic bronchitis of rhonchi, whereas hair crepitations and rales will be described. There is never clubbing in chronic bronchitis, but clubbing is always seen in patients of bronchiectasis because it's a relatively long duration illness in a patient. If clinically we are not able to differentiate, we obviously have a resort to a workup of the patient, where we will be performing a chest x-ray and a HRCT chest, which is the investigational choice for this condition. In the x-ray of this patient, especially on the right hand side, you can notice some markings here of the straight lines. These lines, which are aligned a little at 45 degrees to the base of the lung, are basically dilated airways involving the right lower lobe of the patient. The technical term that is described for both X-ray as well as CT is tram track appearance. In fact, if I zoom into the CT, you can notice these relatively dilated airways. Especially, I'll put pointer at this area where you can notice the dilated airways. I can just point out the air present here. So this is tram track appearance, and then you can see very thick walled airways in the patient. These thick walled is because of the granulation tissue that has come up, and all these airways are relatively filled with pus. So every time you notice this kind of a HRCT image, which I think is one of the easy ones in respiratory system, then you have to answer as bronchiectasis for the patient. The investigations are chest X-ray and a HRCT chest. Chest X-ray will be normal in 99.99% cases. Rarely you could have an image where, especially in the lower lobes, you could be having a tram track appearance. The tram track appearance is more visible, however, on a HRCT chest. Another feature of HRCT chest to be remembered is signet ring appearance. The third term that is used is tree in a bud appearance, but then tree in bud is having actually so many causes ranging from endobronchial tuberculosis to pneumocystis jirovecii that I have verbally said the word tree in a bud appearance, but then I repeat my statement. Tree in a bud can be seen in jirovecii, pneumocystis jirovecii, it can be found in endobronchial tuberculosis. So because the list is so extensive, that is why it is not worth mentioning in either a MCQ or even at this particular point of time in this discussion. Other tests that I will be doing in this patient will be pulmonary function test that will be showing obstructive pattern. So FEV1 FVC ratio in this person will be less than 0.7. In any obstructive airway disease, FEV1 divided by FVC ratio will be less than 0.7. Sputum culture is of great importance in these patients because otherwise you will not be able to give appropriate antibiotics to these patients. HIV basic testing for ELISA at least should be done. Genetic studies are required in these patients to identify cystic fibrosis. However, if I want to identify alpha-1 antitrypsin deficiency in the patient, I can physically check the level of the same in the blood. So alpha-1 antitrypsin levels can be done. In fact, for Kaltenegger syndrome also they have asked what test would be done for Kaltenegger syndrome. So we can either take a nasal or a lung biopsy of this patient where the cilia can be examined. Now the point is that because the biopsy may not be so conclusive, so they are recommended now what is called as a video microscopy. Look at the technology. They are going inside the lung and they are measuring the rate of the beating of the cilia. And in Kaltenegger, the cilia don't beat. So video microscopy of the lung will be done so that we send in a special probe that is evaluating how the cilia are beating. The cilia is a microscopic structure. So video microscopy of the lung or of the nasal sinuses is done to identify presence of Kaltenegger syndrome in a patient. Then I can write RA factor in the patient and antinuclear antibody also, because we are talking about autoimmune diseases which are present. So the search goes on for the etiology, but the diagnosis is based on HRCT of the patient. Next, we'll talk about how would we treat these patients. The first point in the management of this patient is usage of appropriate antibiotics. Initially, you might give empirical antibiotics, but then I will change them to the most appropriate one once the sputum culture report is available with me. If he specifies non-tuberculosis mycobacteria is causing bronchiectasis in a patient, then the treatment of NTM is macrolide, which can be clarithromycin or azithromycin with rifampicin/ethambutol. Do remember that we are not using traditional ATT for management of non-tuberculosis mycobacteria. Mucolytics are especially useful in patients who are having cystic fibrosis because the secretions are very, very thick. So we will be first mentioning the commercial name, that is Dornase, or I can mention the technical name, that is DNase. It simply means that it will break down the consistency of the sputum in the patient. Of importance is chest percussion devices. So the image that is shown here is a percussion device on the chest. The vibrations that it will produce will cause dislodgement of the sputum from the deeper parts of the lung, and then the person can cough it out. So along with this, I need good chest physiotherapy. You see, traditionally in government hospitals, chest physiotherapy is all about, slapping on the back of the patient, which only causes discomfort in a patient, because you can see the look on the face of those patients in our routine wards, when the consultant will come and then he will do some slapping on the back of the chest of the person. Already the poor person is so sick and you are hitting him on the back, it just increases the discomfort level. The poor person obviously can't say anything because it's a government hospital, he has to seek services. But try doing that in a private setup. I mean, you have a patient of lung disease and you're slapping his back and saying exercise karo, most of the time, I mean, patient will give you a quizzical look. Relatives will look at you, come on doctor, what are you talking, he's so sick. So we need technology. Basically, we are lacking in technology as compared to American doctors are not superior to us, they are rather having less knowledge than us. It is just that they use better technology, so the results of the patients are better. So I will use a chest percussion device, I will use chest physiotherapy, I will be using in this person and motivating him to use this device. This is only 200 rupees, but believe me, you try using it in your SP patients, you will get dramatic improvement. That would be incentive spirometry. So if you build up the confidence of the patient, he will be able to cough out the sputum, because there's a limit to how much antibiotics can you give to this patient. My objective was to achieve good bronchial hygiene. So antibiotics and bronchial hygiene are the two mainstays of therapy for management of bronchiectasis in a patient. The biggest complication that occurs in these patients is hemoptysis. Most of the time it would be a massive hemoptysis. They've asked in the exam what is the treatment of choice for massive hemoptysis and investigation of choice also. I'll mention both the MCQs. First, I'll mention the treatment of choice for massive hemoptysis is bronchial artery embolization. If not working, then obviously surgery would be done. Investigation of choice here would be a rigid bronchoscopy. Do not answer flexible fiber optic bronchoscopy. It is a rigid bronchoscopy in a patient, because otherwise the camera will all be dancing in the blood. It will get occluded by the blood. So rigid bronchoscopy is done for massive hemoptysis, which would be in the range of about 600 ml, 500 to 600 ml per day. Then do remember the fact that in these patients, supportive care in the form of gamma globulin, if he's having hypogammaglobulinemia, AIDS treatment has to be given, vaccines have to be given, like influenza vaccine, Haemophilus influenzae vaccine, so that the incidence of lung infections in the patient will reduce. So to prevent the development of bronchiectasis exacerbations in the patient, there are multiple strategies that are being followed. Among the antibiotics, they are recommending to use ciprofloxacin twice a day, 500 milligram for at least 2 weeks. Every month. So it is like antibiotic on for 2 weeks and antibiotic off for 2 weeks. An alternative strategy is to use macrolides in the patient on a daily basis, but this is found to be increasing the level of microbial resistance. I personally have found very good results in tobramycin nebulization. That's mainly for patients of cystic fibrosis. This will be done on a weekly basis. patient will have to come to the hospital at least 4 times per month, but the results are very good because you are preventing the colonization of airways. And tobramycin is especially useful to prevent colonization with pseudomonas, because I told you that it forms a biofilm in the lung. Once pseudomonas goes in the lung, it is end of the game, in a sense that it's very difficult to eradicate the infection. It hides in the nooks and the crannies, it forms a biofilm, it prevents the antibiotics from reaching itself. It's like a horror movie. The bacteria is forming a security system, you can't breach the security system. So I said that it's difficult to manage the patient, and mostly we end up losing the patients or the battle against pseudomonas. So tobramycin is one weapon that you can use. Alternatively, if tobramycin also is not working, we give IV antibiotics for a few days. We admit the patient, though he is having limited symptoms, we admit the patient for cleaning out his lungs. So we call it IV antibiotic cleanouts intermittently. The word is cleanouts, like we are giving IV antibiotics, higher dose antibiotic to clean out the lung, so that the incidence of manifestations in the person will reduce. Apart from this, I have already mentioned regarding the role of vaccines in the patient, and administration of gamma globulin in patients of hypogammaglobulinemia, that will prevent this manifestation from occurring. The incidence of bronchiectasis is substantially reduced nowadays due to the advent of good quality antibiotics and easy availability of antibiotics at relatively cheaper rates. So when I was a student your age, we used to have almost every emergency admission, one bronchiectasis exacerbation used to come, but now the incidence is substantially reduced because of good medical care that we are offering to our patients. So the suppurative lung disease and the complication of it, massive hemoptysis, is rarely seen or less commonly seen nowadays. Thank you so much for listening and having the patience to hear me out that long. Thank you.